Welcome. I want to thank you for your time and your willingness to expand your abilities. Our time together, although limited, potentially can be most important. When one evaluates the current position of clinical endodontics as a healing art, one is struck by the vast differences in which endodontics is understood and practiced from dentist to dentist. Yet, rational methods of treatment are available, precise techniques have been perfected, and technologically driven advances are becoming routine. Verifiable success rates approaching 100% are attainable. The information that I'm going to present will represent the best that has endured from the past and the most recent advances in clinical endodontics. I trust our time together will phenomenally impact your success and personal satisfaction. Let's get started. Over the life of a patient, the dental pulp is vulnerable to injury because of a limited blood supply, it is encased in unyielding dentinal walls, and has terminal circulation. Regrettably, many pulps become compromised because of the invasion of bacteria through the enamel and into tubular dentin. Ideally, if a carious lesion is eliminated early, a simple restoration is the treatment of choice. However, for many patients, progressive and more extensive dental procedures are commonly performed to address recurrent decay, restorative failures, certain periodontal lesions, or specific types of traumatic episodes. It is wise to completely understand and fully appreciate that repeated dental procedures threatens the health of the pulp. In general, pulpal degeneration and disease flow move in a coronal to apical direction. It is fundamental to associate radiographic lesions of endodontic origin as arising secondary to pulpal breakdown and as forming adjacent to the portals of exit. This phenomenon originates in a space exhibiting infinite anatomical configurations and intricacies along its length. Root canal systems commonly contain branches that communicate with the attachment apparatus furcally, laterally, and often terminate apically into multiple portals of exit. Consequently, any opening from the root canal system to the periodontal ligament space should be thought of as a portal of exit through which potential endodontic breakdown products may pass. In this case, we have a gutta-percha point tracing a fistulous tract to a lateral root lesion. This video will emphasize the importance of diagnosis, complete access, shaping the canal such that our irrigants can penetrate into all aspects of the root canal system, and packing in 3 dimensions. The follow-up film shows complete healing. Let's look at some root canal systems. Every dentist could pack in 3 dimensions if they had the shape. The desired shape produces a 3-dimensionally cleaned root canal system that every dentist can pack effectively. A fundamental law of physics states only one mass can occupy the same space at the same time. Shaping serves to remove all contents from the root canal space and creates the opening for 3-dimensional obturation. Shaping facilitates packing by removing restrictive dentin, which allows instruments to work deep, unrestricted by dentinal walls, and to subsequently move thermosoftened gutta-percha and sealer into all aspects of the root canal system. In summary, the shape is critical, not only for effective cleaning, but for 3-dimensional obturation. Consistently producing the shape is one of the strategic cornerstones in the foundation of endodontic success. Although the excitement of a well-packed case is deserved, scientific evidence should support our enthusiasm. Ongoing debate surrounds the question, can a root canal system be totally cleaned? In this inset, you can see that a shaped canal readily receives irrigant. Irrigants can then penetrate and circulate into all aspects of the root canal system and liberate the canal from organic debris. In this cleared section analysis, you can see how irrigants can penetrate off the primary canal and even into very, very fine ramifications in this loop. This lateral incisor was treated in vivo and then extracted. When we look at the SEM, we can see that both lateral canals have been cleaned of debris. Further, a higher magnification view shows that even the dentinal tubules are open and patent. This high magnification reinforces the concept that irrigants can penetrate deep into the tubules and eliminate organic materials. So we have seen evidence to support that shaping facilitates cleaning. Shaping also facilitates packing. Evidence supports a root canal system can be cleaned when we have produced enough shape to fit a fully tapered, non-standardized, fine medium or medium master cone. The idea is to thermal soften the master cone, and utilizing a pre-fit plugger, we can carry a wave of thermal softened gutta percha into all aspects of the root canal system. You can see how hydraulic the pack is in this plastic model. In this clinical photograph, you can see in the buccal canal of the bicuspid, there's gutta percha in the lateral wall, providing powerful evidence of our ability to pack in 3 dimensions. It's reassuring to look at the postoperative film and see a compact pack over all aspects of the anatomy. In this mandibular molar, the clinical crown disrupted and came off during the access preparation. The tooth was subsequently banded to create a reservoir of irrigation. The canals were cleaned, shaped, and packed in 3 dimensions, and the postoperative film shows surplus after filling. As a teaching case, to demonstrate that surplus after filling is irrelevant to the outcome, a buccal flap was reflected, and we can see a massive furcal blowout and a distal infrabony pocket. 2 years later, the patient was reappointed for recall. A simple surgical procedure was again performed, and you can see the inevitability of the bone to rise to the surface after careful cleaning, shaping, and packing. A postoperative film demonstrates complete osseous repair. Evidence-based endodontics provides compelling evidence of the completeness of the pack. In this cleared section analysis, looking at the proximal view of the mesial root of a mandibular molar, we can see a fin, webbing between merging systems, and gutta percha entering into multiple apical portals of exit. We've spoken a lot about the importance of 3-dimensional cleaning, shaping, and obturation, but let's not forget the rest of the seal. Restorations should be placed to protect the clinical crown and to prevent microleakage. Cases should be followed longitudinally to ascertain the status of the health of our patients. There's enormous potential in the field of endodontic diagnosis. Let's look at some information that I think you'll find most exciting. If you have 1,000 active patients in your practice, and assuming that each patient only had 20 teeth, then it could be said that you're the custodian of 20,000 teeth. If you missed endodontic diagnosis just 1% of the time, that would represent 200 teeth that haven't got the proper treatment. If we assume that all endodontics cost $500 per tooth, then you could see that your additional income would be $100,000. You can look at the rest of the information and begin to appreciate how staggering these numbers are if we did a complete diagnostic scheme. There's an old expression that there's a pot of gold at the end of the rainbow, and my assertion is that there's a pot of gold and it's within the teeth that visit you daily. As professionals, it's critical that we listen to the patient's chief complaint. We want to find out what makes their tooth hurt, how long it's been hurting, and when it has been hurting, to what extent they would rate the pain. It's important to listen carefully and record all this information. Endodontic diagnostic procedures may be divided into 3 parts: clinical findings, vital pulp testing, and the radiographic exam. A full mouth endodontic examination starts by retracting the lips and taking a good look into the vestibule. By retracting the lips, we can begin to see all aspects of the soft tissue. A mouth mirror is very helpful to look for caries, existing restoratives, microfractures, and any other anomalies that we might not otherwise see. Here you can see a dens and dente. Looking high in the vault, you can see a fistulous tract. When we take a film of this, you can see the dens. You can see it's a virgin tooth, but the deep invagination and groove allows for microleakage, and look at the massive breakdown endodontically. One of the favorite tests in the profession is percussion. Percussion lets us know if there's attachment apparatus disease. We should percuss both the lingual and the buccal cusp. Another great test is the cue stick or the bite test. We should very carefully place the stick on the tooth that we suspect and have the patient gently bite down and then rock left to right to see if they can create any movement in the event of a microfracture. An alternative to the cue stick is to use the tooth sleuth. This device can be very specifically located on a particular cusp, and having the patient bite can oftentimes reproduce the chief complaint. Marking ribbon can be placed between the biting surfaces of the mandibular and maxillary teeth, and by having the patient move into different working and balancing positions, we can oftentimes mark a prematurity. Palpation is an excellent test and is conducted by running the glove finger high in the vestibule over the anticipated root apex. If the finger is too large, a cue stick can more specifically locate the root apices in teeth that are smaller. Intercellular probing is a very important test because in general, in periodontal lesions, we slowly step down into the lesion, whereas in fractures, oftentimes we have narrow defects. Transillumination can often identify the cracked tooth and help diagnose the fractured tooth syndrome. We should check mobility in all teeth because oftentimes when there's endodontic pathology, teeth will become more mobile and become quite loose as compared to adjacent teeth or contralateral teeth. A good clinical examination involves looking at the interrelationships between the maxillary and mandibular arches. We need to look very carefully at the margins and the soft tissue and the response of the soft tissue to the restorative efforts. We need to look for dark teeth because oftentimes this is an indication of an endodontic problem. We need to look for the presence of a perilous, and when present, they should be traced with a gutta-percha point. Also, oftentimes we'll see a tattoo. A tattoo could be an indication of an old surgical failure or a failing silver point case. Here's a soft tissue anomaly secondary to trauma. Sometimes, when swellings become acute, the tissues are distended and quite painful. In my opinion, every tooth in the mouth should be tested for vitality. My favorite way to conduct the cold test is to use a pencil of ice. We express all the anesthetic out of a carpule. We drop a piece of floss in the carpule a little longer than the carpule and fill the carpule with water. When it's frozen, we have ice readily available. This is wrapped in a 2x2 gauze, and I like to first place the ice on the patient's soft tissue. This way we can begin to eliminate the possibility for a false positive. The best way to conduct the test is to place the ice as close to the free gingival margin as possible, as this is the closest distance into the pulp. The carpules move back and forth, which creates a slurry of cold water which can effectively penetrate into the tooth. The next thing we need to establish are hand signals. We would like to know when the patient first feels the sensation of cold in the tooth, and they'll raise their hand. We want them to keep their hand up as long as the sensation lingers, and we would like them to lower their hand when the sensation dissipates. After establishing a normal baseline on healthy teeth, the dental assistant places a cotton pellet just posterior to the tooth being tested. This prevents a false positive. We're looking very carefully for the immediacy, the intensity, and the duration of each response. Out of all three, duration is most diagnostic and is observed by watching the patient's hand. When a patient reports sensitivity to heat, I like to conduct the hot test so that I can reproduce their chief complaint. A good way to thermosoften gutta-percha is to use Kerr's 5004 touch and heat in conjunction with the hot pulp test tip. Thermal softened gutta-percha is placed on the cervical aspect of the clinical crown. The teeth are left moistened to prevent sticky tacky gutta percha from adhering to the surfaces of the tooth. Hand signals are an excellent way to identify healthy teeth from pulpitic teeth. Again, we're looking for the immediacy, the intensity, and the duration of each response. In some instances, the hot test that was just described does not adequately reproduce the patient's chief complaint. In these instances, we should carefully isolate the tooth and syringe hot water over the tooth because this will bathe the tooth more circumferentially. The third stage of endodontic diagnosis is the radiographic exam. Clinicians should take 3 well-angulated radiographs prior to initiating treatment in order to better appreciate the three-dimensionality of any given tooth. From an endodontic standpoint, preoperative films should include mesial, distal, and straight-on angles. These views will better prepare the clinician for root canal treatment. 3 films in combination are more valuable than a single film alone, and give us important information as to the buccolingual dimensions, concavities, and extra canals. Great endodontics starts with complete access. Great access is an opening for identifying all the orifices, allows for the greater exchange of irrigation, promotes the removal of debris, and is an opening for packing root canal systems in 3 dimensions. Access cavities should be cut so the pulpal roof, including all overlying dentin, is removed. The size of the access cavity is dictated by the position of the orifices. The axial walls are extended laterally, such that the orifices are just within this outline pattern. Access objectives are confirmed when all the orifices can be visualized without moving the mouth mirror. The armamentarium for access cavities is relatively simple. Typically, just 3 or 4 instruments can accomplish the task. When dealing with tooth-colored restoratives, we need to use a number 2 or number 4 round burr diamond. A number 2 round burr diamond is good for bicuspid teeth and anterior teeth, whereas the number 4 would be used in molar teeth. When we're dealing with alloys or metallic restorations, a transmetal burr is useful to reduce unwanted vibration. Once we're into the dentin, surgical length number 2 and number 4 carbide round burrs are the instruments of choice as they serve to move the head of the handpiece further away from the occlusal table. A surgical length tapered diamond is used to finish the axial walls. Gates-Glidden burrs are essential to flare the orifices and give us a smooth transition from the axial walls into the orifices. Ultrasonics is playing an increasingly larger role in the field of endodontics. We use the P5 ultrasonic generator with specifically designed instruments to remove stones, trough for hidden orifices, chase calcified canals, and to finish the access cavity. There's a variety of different ultrasonic instruments that can be utilized with the P5. In general, these instruments are contra-angled, come in increasingly longer lengths, and narrowing cross-sectional diameters. Additionally, these instruments are coated with zirconium nitride. This abrasive allows us to precisely sand away minute amounts of dentin. Isolation is essential in endodontic treatment. Isolation accomplishes soft tissue retraction, protects the oral pharynx, and prevents salivary leakage. Isolation can be accomplished in a one-step procedure. The forceps carefully guide the clamp over the tooth, and the jaws of the clamp are released so that they don't impinge on soft tissue. A 17 Explorer can be used to remove the rubber dam off the tines of the clamp. Dental floss is important to use to get the rubber dam down between the contact points. Oraseal can be further used to isolate the tooth during treatment. Prior to cutting the access cavity, it's important to review our well-angulated preoperative films. We need to observe the relationship between the clinical crown and the underlying roots. We need to see if we can visualize the pulp chamber. And then within the pulp chamber, do we see stones? Great ergonomics and organization facilitate the flow of treatment and keep our patients more comfortable. Looking at the occlusal view of the isolated tooth reminds me of an old expression: start with the end in mind. The outline pattern can be used to guide our clinical actions. Since we're preparing an access window through a metallic crown, we use the transmetal burr. Lay the head of the handpiece over to get it out of your line of sight. Try to penetrate through the gold as quickly as possible. Transmetal burrs, when they're used on their ends, skip and they dance, and so try to cut through the metal so you can use the side of the burr. The side of the transmetal burr has a special sawtooth configuration that reduces vibration and rapidly removes metal. Use the transmetal burr to complete the outline pattern through the gold crown. Once that's accomplished, we can go to the surgical length carbide number 4 round burr. Use it like a brush and sweep back and forth. Notice we're using no water during this procedure because we're not trying to protect the pulp, we're going to be eliminating the pulp, so this improves our vision. The Explorer demonstrates the initial entry into the pulp chamber, traces the expanding outline pattern, and confirms the access preparation is on axes. Let's go back to the 4 round burr and do a little bit more removal towards the pulpal roof. You can see quite an island that appears to be quite a large denticle. Notice the color distinction between this large stone and the surrounding dentin. Sometimes you can just elevate these things out with a Explorer, but if they're large, then you better do more access refinements. A surgical length tapered diamond is used to smooth up the axial walls and make them nice and flat. This refracts light excellently and improves vision. Ultrasonics is an excellent way to blow out a lot of these big stones and free them up so they can be liberated. You can see this thing is large, not only in terms of its mesial, distal, buccolingual dimensions, but notice its thickness. Once the stones liberate from the pulp chamber, diamonds are used to progressively refine the access. Notice the angle of the Explorer. This lets us know a little bit more about the underlying anatomy. Many dentists regretfully begin to instrument canals at this point. For me, there's still quite a bit of work we can do to set up our cleaning and shaping. Here's a free denticle. These can be teased up and blown out with air. And sometimes there'll be projections of denticles extending down into the canals. If we're careful, we can tease these up as well so that it'll free up the canal so we can begin our clean and shaping. Tin files are used for a couple reasons initially. First of all, we might be able to pull up another stone, which can open up the orifice level, but also the angle of the tin file gives us some sense of appreciation for the angle of the canal coronally. Gates Gliddens are used at low speed. The head of the handpiece is moved in a big orbital arc to flare the orifice so that it can receive files passively and easily. Use the belly of the Gates Glidden on the axial walls. Microscopes, in combination with ultrasonics, allows us to perform microsonic techniques. Notice the assistant using continuous air as we sand away tooth structure precisely. This gives us an unobstructed line of sight. When using the endo tip number 3, set the power on the P5 at about 6 or 7. Notice how we have unobstructed vision into the mesial aspect of the pulp chamber. We're not looking at the back end of a bulky handpiece. Use this in a painting brush-like motion. Here we've uncovered an extra orifice between the MB and the ML orifices. When the tip of the file engages, we get handle flutter. Smaller Gates Gliddens can be used like a brush, using their bellies to remove a little bit of dentin towards the MB line angle. This allows a tin file to slide smoothly down the axial wall and transition into the orifice. This is a great opening for clean and shaping. When we refine our pulp chambers with ultrasonics, we set the stage for more predictable cleaning and shaping procedures. The finished access cavity can be topped off with an appropriate irrigant and this sets the stage for scouting the canals. Let's look at an access cavity of a maxillary molar. This first molar has a fissulous tract that's being traced with a gutta percha point. Notice the crown extends gingivally and we cannot identify the pulp chamber. Access cavities need to be well planned so that we can avoid iatrogenic events. Again, we're looking at the occlusal view of the isolated tooth. In this instance, it's a porcelain fused to metal crown. The outline pattern guides our clinical actions, but in a maxillary first molar, we need to be aware of the presence of the MB2, which is present over 90% of the time. Therefore, our access cavity needs to expand at the expense of the mesial marginal ridge. The rotary cutting tool of choice is the round burr diamond. Voluminous amounts of water is used continuously as we begin to paint like a brush on the porcelain surface. Light brush cutting action eliminates the potential for fracture. As we paint with the diamond, we'll begin to see the underlying substructure. Be sure to take your time, don't be in a hurry, and lay the head of the handpiece over towards the mesial. This will give you a line of sight so that you can watch the burr work. Sometimes I like to drag the axial walls up just a little bit more to give me better access and visibility into the chamber. The transmetal burr is laid over on the side, as we've previously mentioned, and it's now cutting on its side. Once we've penetrated through the metal, we go to the surgical length carbide number 4. Again, notice the line of sight down the shaft of the burr. We can always watch the rotating head cut, and we're using that head like a brush, painting buccolingual and mesial to distal as we progressively move closer and closer to the roof of the pulp chamber. At a higher magnification, you can see that we've just broken through the pulpal roof towards the MB. The Explorer demonstrates the initial entry into the pulp chamber. This site is where we'll place the number 4 surgical length round burr. We drag up, and as we lift the head of the burr up, we de-roof the pulp chamber progressively, and we continue this until the roof is completely removed. Notice this leathery tissue that's occupying a portion of the pulpal floor. Following the use of carbide round burrs, the axial walls are irregular. Therefore, we can true up these axial walls with a surgical length tapered diamond. A trick I found useful is to use just the coronal 2/3 of the cutting grit to expand the access cavity. This keeps the end of the diamond free from gouging in and ledging the internal walls. Once the access cavity has been expanded, then we can use the apical 1/3 of the diamond to marry the axial walls with the pulpal floor. Slightly adjust the patient's head so you have an excellent line of sight into the pulp chamber, and importantly, so you can watch just the coronal 2/3 of the diamond work. The tip of your diamond wants to be free as you sweep back and forth on the mesioaxial wall. As you ramp around the line angle from the MB to the buccal, be sure to keep the free end of the diamond off the pulpal floor. Use the diamond like a piece of sandpaper. Lightly carry the diamond around these internal walls, just sanding away and refining until the axial walls become nice and flat. This refracts light and gives us excellent added vision into these deep pulp chambers. The Explorer is pointing to the DB, the MB, and the related groove, which commonly holds the MB2. And of course, we also have a palatal orifice. The tin file is inserted into the DB not to begin cleaning and shaping, but just to observe the relationship of the file to the long axis of the canal. As we slide the instrument down the distal buccal line angle, it hangs up a little bit on an outcropping. Remember, the pulpal horns extend out towards the buccal and create a shelf of dentin. Gates Gliddens can be used in an orbital arc to face off and flare the orifice. We use the belly of the GG to further refine and blend the coronal aspect of the canal into the axial walls. This allows the instruments now to pass easily down the wall, slide into the orifice to initiate clean and shaping procedures. Again, a hand file can be used to ascertain the long axis of the canal. Notice how the handle's off axis. Flexible Gates Gliddens can be used like a brush, and we can paint with the belly of the GG to remove restrictive dentin. This is done very precisely and carefully on the outstroke. We can lay the belly over towards the MB2 and refine that area as well. Once we've done a few painting motions, we've improved access, and now the tin file can slide easily down the MB line angle into the MB system. The Explorer begins to map out the anticipated location of the MB2. Sometimes calcific tissue can be freed up, but generally this is an area that needs refinement. Ultrasonics is an excellent way to remove precise amounts of dentin. The entry angle of the MB2 into the pulp chamber is very acute. By removing tooth structure at the junction of the axial wall and the pulp chamber floor, this will give us a better straight line approach into the MB2 system. Again, sand, carrying the ultrasonic instrument in a brush-like motion to remove selective amounts of dentin. Since all ultrasonic work is performed dry, we need to irrigate periodically to remove the debris that is accumulated in the pulpal chamber floor and specifically in the groove off the MB1. Notice how the tin file slides effortlessly down the mesioaxial wall and into the MB2. Following ultrasonic work, you can see that we've even improved access by noting the position of the handle of the 15 file standing up straight and tall. Let's look at some tricks for locating canals. Radiographs provide better appreciation for root canal system anatomy. We need the three views as we've previously spoken about. This is a distal view. Notice how it throws the MB root anteriorly. By taking multiple view films, we have a better appreciation for the buccal lingual dimensions of any given tooth. This is a straight-on view. You can see the MB and the DB are framed equidistant between the palatal system. Notice the instruments in the MB1 and the DB system. Notice the abrupt curvature apically on the tin file in the MB system. The distal view superimposes the DB system over the palatal canal, but importantly, frees up the MB root. Notice the abrupt apical curvature of the tin file in the MB2 system. This particular angle is far from the distal. Notice that it has thrown the DB just anterior to the palatal, but importantly, we begin to see not only the tin file in the MB3, but we also see the concavity on the furcal side of the MB root. The packed case reveals all the anatomy and demonstrates the thrill of the fill. Another important idea for locating canals is having great vision. Here we see a headlamp and magnification glasses. Transillumination is another idea, and the dental assistant can hold a fiber optic wand either above or below the rubber dam playing light buccal to lingual, and at high magnification, with the microscope turned down, notice the groove off the MB1. Microscopes play an essential role in locating canals because they give us unsurpassed vision and coaxial light. We also have a range of power between 2.5x and somewhere around 20 power. Magnification plus lighting equals vision. In this high-powered view, we can see the lingual canal. Most clinicians find the facial system, but the one that's usually missed is underneath the cingulum. Access cavities should be drugged towards the lingual to uncover these second systems. Notice the tin file working into the lingual canal. This mandibular bicuspid was treated in the mouth and subsequently extracted because it was failing. I performed a post-mortem. Firm Explorer pressure identifies the system. Firm Explorer pressure oftentimes can be used to punch through secondary dentin. Irrigation clears out the debris. Now a tin file can be slid into this system. A little bit of watch winding effort brings the instrument down and towards the foramen. If we look at the extraoral view, it's a little bit humbling, noticing this aberrant root. Oftentimes when we're working into an orifice, there may be a deep division. Sometimes these get overlooked and completely missed. It's hard to see this deep into the tooth because typically our vision's obstructed by the handle of the file. A good idea would be using a micro opener. These are files that don't have handles to obstruct our vision. They have 7 millimeters of cutting blades and they're double and triple tapered, providing more rigidity. These are stainless steel and they can be pre-curved. Our vision is blocked with the tin file, but you can see we have unobstructed vision using a micro opener. This instrument can be placed into the orifice, and using slight pull strokes we can shave away dentin to improve our access. Once the access is improved, a conventional tin file can be slid down the respective axial wall, slid into the orifice, and can begin to move apically. This graphic demonstrates a deep division in the distal root. A clinical film also demonstrates the distal root has a deep bifidity in the apical 1/3. Micro openers can pass through the straightaway portion of the canal and help uncover these deep divisions. Note the 3 portals of exit in the mesial root. Another idea for finding extra canals is to irrigate with sodium hypochlorite. When sodium hypochlorite reacts with organic tissue, it liberates oxygen. We call this the bubble or the champagne test. Another trick for finding extra canals is to appreciate in the maxillary first molar that the MB2 is never on the imaginary line between the MB1 and the palatal. This canal is typically mesial to that imaginary line. Therefore, access cavities need to be expanded so we can identify this important orifice and treat this system. You can see in this 3/4 view on a graphic that the entry angle of the MB2 into the pulp chamber is very abrupt. Ultrasonics and long tapered diamonds remove the triangle to improve access into this system. Oftentimes, a lip of dentin meets the pulpal floor and forms a groove. Many colleagues are probing tenaciously in this groove to find the system, but it needs to be recognized that the second canal is under this lip of dentin, and this lip of dentin needs to be removed with ultrasonics. When we do this work, we call it the white line test, because in necrotic teeth, dental debris moves into the isthmus area and makes a white line, and we can track the white line into a roadmap where to go to find the MB2. In vital cases, blood will frequently move into these isthmus areas and can be used as an indicator where the underlying anatomy exists. Notice the MB1 and related groove, but notice the long groove off the DB. We call this the red line test. With careful resection and identification and thorough clean and shaping, the post-op film reveals an MB1, an MB2, a treated DB1 and DB2, and a palatal system. 5 systems in this maxillary first molar. In provisionalized dentistry, it's excellent to use a GC plier with yellow packings. These are dipped in emery stone to prevent dangerous slippage. By removing the crown, we have better orientation to the underlying tooth structure, and we're also closer to the pulp chamber. In restorations that have been definitively cemented, we need to use something like the metal lift. This device allows us to push down on solid tooth structure while at the same time lifting up on the dentistry. We need to be mindful, though, if porcelain flexes 1/10,000th of an inch, it will fail. Another important idea for locating canals is to carefully probe the sulcus. This can give us important information as to the relationship between the long axis of the clinical crown and the underlying root. Another concept for finding missed canals is to use orifice symmetry principles. In this failing case, I'm locating a distal lingual orifice. Notice the distal buccal is not centered between the MB and the ML. This gives us the confidence to chase towards the distal lingual to find the missed system. This is a preoperative film of the anterior abutment. Notice that this tooth appears to have 3 distinctive roots. Notice the pulp chamber is very small, and you can just barely observe it just below the margin of the crown. Using the principles we've previously talked about, let's take the bridge off so we'll get closer to the pulp chamber and have a better orientation to the underlying roots. Following coronal disassembly and isolation procedures, an access cavity was prepared. Typically in a first bicuspid, there's a single buccal orifice symmetrically positioned across from the lingual. In this instance, the MB is anterior to that imaginary line, and the DB is just posterior. Here the O8 file is being pulled down into the distal buccal system. Following endodontic treatment, the bridge was reassembled, and the postoperative film shows the work. There's an old expression, all roads lead to Rome. Looking down into this maxillary molar, you can look at color. Color roadmaps the anatomy. Color leads us to orify. In this instance, a little ultrasonic work removes restrictive dentin and allows a tin file to be fed into this force system. Endodontic treatment can be simplified by dividing the entire procedure into a series of smaller steps. With exceptions, the vast majority of teeth range from 19 to 25 millimeters in length. Most clinical crowns are about 10 millimeters, and most roots range from 9 to 15 millimeters in length. If we divide the roots into coronal, middle, and apical 1/3, then each third is between 3 and 5 millimeters in length. Fulfilling the mechanical objectives of cleaning and shaping also achieves the biological objectives and promotes predictable success. In a continuously tapering preparation, the canal shape must flow and progressively narrow in an apical direction. Starting at the orifice and moving apically, every cross-sectional diameter of the finished preparation should decrease with the smallest cross-sectional diameter at the apical terminus of the canal. It is important that the original anatomy is maintained. Canal systems move through multiple geometric planes and curve significantly more than the roots that harbor them. The economy of the preparation is always a conscious balance between a canal that is three-dimensionally cleaned, shaped, and obturated, and conserving maximum root structure. It is essential the position of the foramen is maintained. Gently and minutely enlarging the apical foramen without relocating or losing its position represents excellent endodontic preparation skills. To maintain the position of the foramen during treatment, small clearing files are passed to and minutely through the apical terminus to prevent the accumulation of dentine mud and, importantly, to maintain patency. Keeping the foramen as small as practical is a discipline, improves preparation results, and promotes confidence during three-dimensional obturation. Clinicians should recall that the mathematical expression for the area of a circle equals pi r squared, and as such, doubling the file size apically increases the surface area to seal by 4-fold. Certain teeth, like this C-shaped molar, may require that the apical foramen be finished to a size 40 or 50. The clinician should create shape coronal to the radiographic terminus to provide resistance form to hold gutta percha and eliminate the potential for packing overextensions. Failure to respect and appreciate the biological and mechanical objectives of cleaning and shaping increases frustration and predisposes to needless complications such as blocks, ledges, apical transportations, and perforations. These iatrogenic events can be attributable to working short of the radiographic terminus, attempting to negotiate and prepare the apical 1/3 of the root canal first, the instruments, and their methods of use. Generations of dentists have been trained to work short of the radiographic terminus. Every dentist who has worked short has experienced the frustration of an apical blockage. A loss of working length occurs due to the compaction of collagenous tissue apically and/or the accumulation of dentine mud. In the instance of the lost foramen, many clinicians become frustrated and aggressively attack the obstacle, which serves to inadvertently condense and pack debris apically. Working arbitrarily short of the radiographic terminus in an apically blocked canal predisposes to a ledge. A transportation results because there's been failure to pre-enlarge the canal and occurs because carrying larger, progressively stiffer instruments to length begins to relocate the foramen on the external root surface. If persistent file grinding continues in a blocked and ledged canal, a perforation may result. Let's look at the preparation sequence. Cleaning and shaping outcomes are significantly improved when the coronal 2/3 of the canal is first negotiated, then pre-enlarged. When the coronal 2/3 has been optimally pre-enlarged, access is available to more predictably and safely scout and negotiate the apical 1/3 of a root canal system. Finishing the apical 1/3 provides deep shape where the canal progressively tapers towards its terminus. Stainless steel ISO 02 tapered sizes 10 and 15 hand files are used to scout the coronal 2/3. Scouting files can provide three important pieces of information. Scouter files immediately reveal the cross-sectional diameter of a canal and provide information as to whether the canal is open but restricted, or calcified. Scouter files confirm the presence or absence of straight-line access. Clinicians can observe the handle position of an instrument to see if it is upright and paralleling the long axis of the tooth or skewed off axis. Scouter files can provide important information regarding root canal system anatomy. The pre-enlargement of a canal can be accomplished with just one or two ProTaper rotary shaping instruments, and the more important breakthroughs are: pre-enlargement gives the clinician better tactile control when directing small pre-curved negotiating files into the delicate apical 1/3 microanatomy. Pre-enlarged canals hold a greater and more effective volume of irrigant, which serves to enhance cleaning. Pre-enlarged and tapered canals dramatically promote the removal of dentine mud. Pre-enlargement procedures decrease post-treatment problems, as the bulk of the pulp and, if present, bacteria and related irritants have been removed. Pre-enlargement procedures generally improve diagnostics. A pre-enlarged canal passively accepts a larger file into the apical 1/3, where its terminal extent is easier to visualize radiographically. In fact, electronic apex locators are more accurate when utilized in pre-enlarged canals, as instruments are more likely to snug into dentin towards their terminal extents. Pre-enlarged canals generally accommodate small pre-curved hand files, which can be utilized to gather specific information regarding the canal's apical 1/3 cross-sectional diameter and anatomy. Clinicians need to appreciate the 5 commonly encountered anatomical forms, which include canals that merge, curve, recurve, dilacerate, or divide. Creating a canal preparation whose cross-sectional diameter progressively narrows and is smallest apically allows for controlled, three-dimensional obturation. Finishing is the sine qua non of excellence and is an opening for packing root canal systems in 3 dimensions. Working length and patency are so interrelated that they must be discussed together. The breakthrough to apical 1/3 finishing procedures is canal patency and is performed by gently pushing small, highly flexible files to the radiographic terminus. To ensure patency, the file tip is intentionally inserted minutely through the foramen to discourage the accumulation of debris. Importantly, working a small, flexible file to the radiographic terminus will encourage the elimination of dental pulp, related irritants, and dental mud. Establishing and maintaining patency are non-harmful biological events when one reflects on the blood supply and immune capabilities present in the periradicular tissues. Before initiating treatment, superimpose a pre-curved and measured tin file over a well-angulated radiograph to establish a tentative working length. Then introduce the pre-curved and measured tin file. When patency is established and we have an accurate working length, then the apical 1/3 can be finished in a variety of ways. A smooth-flowing preparation will readily accommodate a non-standardized master cone of gutta percha. The postoperative film demonstrates deep shape and that we fulfilled the mechanical objectives for cleaning and shaping. The working film of the mandibular bicuspid demonstrates the concepts we've been talking about. Working to the radiographic terminus allows irrigants to penetrate and circulate into all aspects of the root canal system. Fully shaped canals readily receive a non-standardized fully tapered master cone. Notice all the portals of exit that have been sealed. The endo ring is an excellent device for the dental assistant. Not only can it hold the instruments, but it has a measuring ruler and a small well to place a rubber stop so that they can be very accurately placed on the shaft of the file. In the front row, we have a stainless steel 10 and 15 with unidirectional stops. The 20, 25, and 30 are still stainless steel, but they're flexo files which give us added flexibility. In the back row, we have nickel titanium. The dental assistant can conveniently pass the endo ring into the clinical field so that instruments can be easily exchanged. ISO-sized instruments are available in different lengths, but in common they have 16 millimeters of cutting flutes. The cross-sectional diameter at the first rake angle of any file is termed D0. 1 millimeter coronal to D0 is termed D1, while 2 millimeters coronal to D0 is called D2, and so forth. The most shank-side cutting flute is 16 millimeters coronal to D0, represents the largest diameter and most active aspect of the instrument, and is termed D16. Each instrument receives its numerical designation or file name from its D0 diameter. Since ISO files have a standard taper of 32 hundredths of a millimeter over 16 millimeters of cutting blades, then the taper of any specific instrument is 0.02 millimeters per millimeter. The new ProTaper instruments represent a revolutionary progression in root canal preparation procedures. The basic series is comprised of 3 shaping and 3 finishing instruments. Let's look at the shaping files. The auxiliary shaping file, or Shaper X, has an overall length of 19 millimeters, providing excellent access in restrictive areas. Shaper X has a D0 diameter of 0.19 millimeters, a modified guiding tip, 14 millimeters of cutting blades, and a D14 diameter of 1.2 millimeters. Shaper X has a much faster rate of taper from D0 to D9 as compared to the other 2 shaping files. For an example, approximately at D6, D7, D8, and D9, the instrument's cross-sectional diameters are equivalent to 0.5, 0.7, 0.9, and 1.1 millimeters respectively. This file is used to optimally shape canals in shorter roots, relocate canals away from external root concavities, and to produce more shape, as desired, in the coronal aspect of canals in longer roots. Shaping files number 1 and 2 have a D0 diameter of 0.17 and 0.20 millimeters respectively. Modified guiding tips and their maximum flute diameters approach 1.2 millimeters each. Additionally, each shaping file has 14 millimeters of cutting blades. The shaping files have increasingly larger tapers over the length of their cutting blades, allowing each instrument to engage, cut, and prepare a specific area of the canal. Shaping file number 1 is designed to prepare the coronal 1/3 of a canal, whereas shaping file number 2 enlarges and prepares the middle 1/3. Although both instruments optimally prepare the coronal 2/3 of a canal, they do progressively enlarge its apical 1/3. 3 finishing files have been developed to address the obvious variations in cross-sectional diameters that canals exhibit in their apical 1/3. The finishing instruments have D0 diameters of 0.20, 0.25, and 0.30 millimeters, and between D0 and D3 they taper 7, 8, and 9% respectively. From D4 to D14, each instrument has a decreasing percentage taper, which increases flexibility and reduces the potential for dangerous taper lock. Although these instruments have been designed to optimally finish the apical 1/3, they do subtly and progressively expand the shape in the middle 1/3 of the canal. Generally, only one finishing instrument is required to prepare the apical 1/3 of a canal, and the one selected is based on its curvature and cross-sectional diameter. A unique feature of the shaping files is their progressively tapered design, which clinically serves to significantly improve flexibility, cutting efficiency, and typically reduces the number of recapitulations needed to achieve length, especially in tight or more curved canals. Additionally, a progressively tapered file engages a smaller zone of dentin, which reduces torsional loads, file fatigue, and the potential for breakage. Another unique feature of the ProTaper instruments relates to their convex triangular cross-section, which reduces the contact area between the file and dentin. This greater cutting efficiency has been safely improved by balancing the pitch and helical angles, which in combination prevents the instruments from inadvertently screwing into the canal. All the ProTaper instruments effectively auger debris out of the canal. Generally, only 3 instruments are required to produce a fully tapered canal that exhibits uniform shape over length. The ProTaper instruments may be utilized in a gear reduction electric handpiece at 300 RPMs. Programmable features allow us to select the specific torque for each instrument. The assistant plays an important role during the exchange of ProTaper files. By stepping on the rheostat, the flat lines up, the instrument's locked into place and can be readily used. With experience, certain electronic apex locators can provide valuable, accurate, and reliable information as to working length. In use, the clip is attached to the patient's cheek, while the lead is attached to the shaft of the file. As the file moves progressively deeper into the canal, we're at length when the display panel reads apex. 3 intercanal irrigants are commonly employed in clinical endodontics: a 5.25% solution of sodium hypochlorite, viscous chelators such as Glide or RC Prep, and an aqueous chelator such as a 17% solution of EDTA. Sodium hypochlorite has the unique ability to destroy spores, viruses, and bacteria, and importantly, can digest vital and necrotic pulp tissue from all aspects of the root canal system. Warming sodium hypochlorite to approximately 60 degrees centigrade or 140 degrees Fahrenheit significantly increases the rate and effectiveness of tissue digestion. Clinically, a 60 degrees centigrade warm water bath is achieved by placing a beaker of water on a hot coffee plate. Preloaded syringes of sodium hypochlorite may be warmed by placing them in this water bath. The dental assistant passes the Irrigain syringe in with a cupped hand. The doctor holds the Irrigain syringe and always keeps it in motion when dispensing irrigant to prevent the needle from inadvertently locking up in the canal. Slowly injecting irrigant in combination with continuous hand movement will virtually eliminate sodium hypochlorite accidents. The purpose of a viscous chelator is for lubrication, emulsification, and holding debris in suspension. Glide can be obtained in a preloaded syringe, and an appropriate amount is then offloaded into a small disposable syringe for single patient use. When indicated, the pulp chamber is filled brim full with the chelator. The lubricant encourages the file to slip and slide by intercanal calcifications such as pulp stones or sheaths of fibrotic tissue. A viscous suspension of a chelator advantageously promotes the emulsification of vital tissue and facilitates the negotiation of a canal. Research has shown that a 1-minute rinse with EDTA eliminates the smear layer, opens up the dental tubules, and provides a cleaner surface against which obturation materials may adapt. Labeled syringes are important so that we always know what we're introducing into a tooth. Clinicians should irrigate with EDTA during and after canal preparation procedures. Some activate the irrigant with hand files, whereas others use ultrasonic devices. The problem with ultrasonic devices is they can cause defects in the canal wall. Currently, tapered microbrushes are being field tested. Evidence supports that a microbrush can produce clean root canal walls with open dental tubules. The microbrushes will be on the market soon. When endodontic treatment is properly performed, there is enormous potential for success. To maximize success, it is wise to appreciate root concavities, root curvatures, and root canal systems. Access cavities involve removing the pulpal roof. Once that's performed, we fill the pulp chamber brim full with the appropriate irrigant. Most canals exhibit enough space to accommodate a tin file. The instrument is fed into the canal and passively pushed apically as its handle is gently rocked back and forth. A 15-degree clockwise rotation is followed by a 15-degree counterclockwise rotation of the file handle. Repeating this motion pulls the file down and into the canal. The handle is rocked back and forth until it's just snug. When it's snug, we pull, and importantly, we're cutting on the outstroke, away from the terminus, and out of the canal. Generally, about 6 feeded-in pole cutting cycles achieves a smooth and reproducible glide path. When scouting the coronal two-thirds of a canal, clinicians need to be aware of the handle as it relates to the long axis of the canal. The next instrument in the series is the 15 file. Recall it's a 15 at D0 and a 47 at D16. This implies that this instrument can create more space than its numerical name would suggest. Feed it in until the handle is just snug, and when we pull, we're cutting importantly out of the canal, away from the terminus, and towards the greater cross-sectional diameters. Another 6 cutting cycles completes the work. After using the 10 and the 15 scouting files, a reproducible glide path exists in the coronal two-thirds of the root. This allows us to come in with our first ProTaper rotary shaping file. Shaper 1 is a 17 at D0 and has multiple tapers over its 14 millimeters of cutting blades. This instrument is carried passively into the canal and allowed to float down through the root. When light resistance is encountered, the instrument is withdrawn. Oftentimes we'll carry the instrument back in and recapitulate to refine, smooth, and increase the glide path. Clinicians need to recognize that the reason the handles of the hand files are off axis is because of the internal triangle of Denton. To remove this, the instrument of choice is Shaper X. It's a 19 at D0 and it has a 19% taper over the first 9 millimeters of its cutting blades. The hero part of this instrument is its middle 1/3. That's where we want to cut on the outstroke. Allow the instrument to float into the canal until passive resistance is met. Then lift up and begin to paint and carve and eliminate dentin on the outstroke. Once space is made laterally, allow the instrument to move in a little bit deeper, again until light resistance is met. Then cut on the outstroke to relocate the canal away from focal danger. Confine the instrument to about 2/3 of its cutting blades below the orifice. After using Shaper X, the coronal 2/3 of the root canal system will be optimally prepared. To fully appreciate the work of Shaper X, let's look at the before and after views. Shaper X has also generated an enormous amount of debris, so we should irrigate to remove this loose debris. A tin file is carried into the root, and we recapitulate to break up pockets of resistance. The tin file is moved in short amplitude strokes to move debris into solution. We then re-irrigate to flush out this debris from the root canal space. A tin file is then carefully measured. The rubber stop is torqued to simulate the curvature of the root. The pre-curved tin file is passed through the pre-enlarged canal, and its handle is reciprocated gently, moving it deeper into the canal. Patency is now established. The instrument is moved in and out gently and minutely until the instrument is free and loose. By taking the tin file 1 millimeter through the foramen, we've transitioned the foramen to at least a 12. Recall that the 15 file is 50% bigger at D0 than the 10. The pre-curved 15 file is inserted and gently worked to length. If necessary, we can use chelators to encourage the mechanical objectives. When the 15 file is at the anticipated length, we can confirm working length with either a radiograph or using the electronic apex locator. Now we need to verify the glide path. To accomplish this, the 15 file is picked up 1 millimeter and gently moved to length. Now it's picked up 2 millimeters and pushed to length. In general, if we can move the 15 file over a range of 3 to 5 millimeters, we have a reproducible glide path for rotary instruments to follow. Shaper number 1 is 17 at D0 and can easily follow this glide path. Allow it to float down through the root. If any resistance is encountered, remove the instrument, re-irrigate, recapitulate, and then re-irrigate. This will allow the instrument to achieve length. When you reach length, remove the instrument immediately because the shape has already been cut. There is no need to pump the instrument or rotate at length. Following the use of Shaper 1, we should re-irrigate and recapitulate. Be sure to carry the tin file to the terminus and then confirm patency. Work the instrument up and down in short amplitude strokes to move debris into solution and then re-irrigate. The next instrument in the series is Shaper 2 and follows the use of Shaper 1. It's a 19 at D0 and has progressive tapers over its 14 millimeters of cutting blades. The instrument is carried into the canal and allowed to float through the root canal space. Generally, it can achieve length on the first pass. When the instrument arrives at length, immediately withdraw the instrument as the shape has been cut. Following its use, we need to irrigate and recapitulate and re-irrigate. Following the use of our first two shapers to length, it is wise to recall that working length will decrease as we've created a more direct path to the radiographic terminus. It would be wise then to reconfirm working length prior to finishing the root canal space. Our first finishing instrument is Finisher 1. It's a 20 at D0 and has a 7% taper. This instrument will easily and readily follow the pathway of the previous shapers, and just shy of length, the instrument is immediately withdrawn as the final shape has been carved. There are 3 pro-taper finishing files, and their D0 diameters are 20, 25, and 30. As such, following their use, the foramen must be gauged using correspondingly sized 20, 25, and 30 hand files. Following the use of Finisher 1, the foramen needs to be gauged to ascertain if it's truly a 20 or larger. A 20 hand file is carried to length. If the 20 hand file is snug at length, the case is ready to pack. In the event the 20 file is loose at length, proceed to Finisher number 2. Finisher number 2 is a 25 at D0 and it has an 8% taper. Following its use, gauge the foramen with a 25 hand file. If the hand file is snug at length, the case is ready to pack. If the hand file is loose, proceed immediately to Finisher 3. Finisher 3 is a 30 at D0 and has a 9% taper. And, following its use, we again gauge the foramen using a 30 hand file. If the 30 hand file is snug at length, we're ready to pack. In the event the 30 hand file is loose, there are a variety of techniques that we'll talk about shortly that can finish the apical 1/3. Currently, I'm using microbrushes to optimally finish the root canal preparation. Microbrushes can be selected, activated, and used in a rotary handpiece. A high magnification demonstrates how the bristles are attached and shows the helical angle that augers debris out of the canal. Finishing an irrigant-filled shaped canal with a microbrush has been shown to significantly enhance the cleanliness of the preparation. Tapered microbrushes enhance cleaning as bristles deform into the irregularities of the preparation and move debris into solution where it can be liberated from the root canal space. The clinician must make a decision whether to finish the apical 1/3 manually or with nickel titanium rotary shaping files. How we do this is we check for the glide path. As we spoke about earlier, when the 15 file is snug and at length, we lift it up and without reciprocating the handle, we push it directly back to the radiographic terminus. Then we pick it up 2 millimeters and 3 and 4 and 5 millimeters, and in general, if the instrument cannot be slid to length because it hangs up on a bifidity or a canal anomaly, then we should consider manual finishing. We pre-curve 10 and 15 hand files. We exaggerate the curve, we use unidirectional stops, and we work the instrument past the bifidity. When the instrument is at length, we work it gently and repeatedly in vertical amplitude strokes. Gauging and tuning with ISO O2 tapered hand instruments is a technique directed towards confirming a uniform taper in the apical 1/3 of the root canal preparation. The clinician begins to gauge the most apical cross-sectional diameter of the canal when a hand or rotary instrument just snugs into the terminus and resists further apical travel. In order to prove with certainty that the diameter of the file at length represents the true size of the foramen, the clinician must then tune. Tuning is the clinical activity of recapitulating through a series of successively larger instruments and working them until they are observed to uniformly back out of the canal. The interval of backout between successively larger files should not be greater than 1/2 millimeter. The file that snugs in at length only represents the true most apical cross-sectional diameter of the canal if each progressively larger instrument uniformly backs out of the canal in 1/2 millimeter intervals. Gauging and tuning verify deep shape and are an opening for cone fit and packing in 3 dimensions. In summary, if the 20 file represents the instrument that was snug at length, then every successively larger instrument moves progressively short of the radiographic terminus. Following gauging and tuning procedures, one can simply look at a series of instruments and note the position of the rubber stops. Generally speaking, when you have deep shape, you can see a progressively larger gap between the top of the stop and the plastic hub on the handle. In this maxillary first molar, the mesial buccal root in its apical 1/3 is quite complex. This is an example where manual finishing procedures are indicated. Again, in a mandibular second molar, you can see that the distal root has trifidity in its apical 1/3. Whenever the canal makes a sudden change in cross-sectional diameter, this would be an indication where rotary instruments may separate. This is a maxillary first molar. Notice the calcification in the pulp chamber, and then be aware of the stones that appear to be projecting into the root canal system. Specifically, if we look at the MB root, we can see it's multiplanar. There's a curvature in the coronal 1/3, there's a distinctly different curvature in the middle 1/3, and there appears to be recurvature in the apical 1/3. Following complete access, a 10 hand file gives us information regarding cross-sectional diameter. We can observe the handle to see if it's on or off the long axis, and we can begin to determine if we have complex or straightforward anatomy. The 15 follows the 10. Another 5 to 6 cutting cycles refines the glide path, carries more irrigant deeper into the anatomy, and paves the way for rotary shaping files. Shaper number 1 follows the use of the Scouter files and can be introduced whenever we have a smooth and reproducible glide path. Let the instrument float down, and when the rubber stop is just short of the reference point, the instrument is withdrawn. We can observe the debris on the flutes, and it can tell us quite a bit about where the instrument's actually cutting in the canal. Following Shaper 1, we can use either Shaper X or Shaper 2. In this instance, I will use Shaper 2 with the white identification ring, since the handles of the 10 and 15 files were on axes. Let the instrument float into the canal. I like to use the pencil lead analogy. Push no harder than you are writing with a pencil without breaking the lead. When we've achieved the level of where Shaper 1 went, the instrument is immediately withdrawn. Irrigate and recapitulate and re-irrigate. The 10 file is easily passed through the pre-enlarged canal. A pre-enlarged canal will generally allow the 10 file to slide to length. Once we're at length, stay at length, and carefully and repeatedly explore and refine the glide path. When we have a smooth and reproducible glide path, patency is established. Check the glide path by taking progressively longer strokes. The Precurve 15 file follows the use of the 10. Its handle is gently reciprocated in a back and forth watch-winding motion. This will typically pull it into the canal so it can achieve length. In a pre-enlarged canal, we've made a more direct path to the terminus, so at this point we should be thinking about checking our working length. After confirming working length, it's time to irrigate and fill the chamber brim full with sodium hypochlorite. The 10 file is passed through the canal, and we maintain patency. Little short amplitude strokes ensure patency, and progressively longer strokes confirm the glide path. We're now ready for the use of Shaper number 1. This instrument has a purple identification ring on its handle. The instrument is carried into the canal, and generally it can achieve length quite easily. Sometimes we'll lift the instrument up just a little bit to allow debris to more effectively auger up its cutting blades. Once we've achieved length, the instrument is withdrawn. Following the use of Shaper 1, we irrigate, recapitulate, and re-irrigate. This gives us confidence to proceed with Shaper number 2. Shaper number 2 will generally follow the glide path and achieve length on its first pass. When we're at length, the instrument is immediately withdrawn as the shape has been cut. Again, we'll irrigate and recapitulate and re-irrigate. The tin file is gently placed to length. Patency is again maintained. Little short amplitude strokes assure the glide path and pave the way for the 15. At this stage of treatment, the 15 file will readily drop to length. When it's at length, it's wise to reconfirm working length, and I use the electronic apex locator. The lead lassos the shank of the file, and the reciprocating handle motion is gentle, and we just minutely move the file away from the terminus. Then the file is slid back to length. If we get a stable reading on the display unit of our electronic apex locator, we have confidence of working length and we can proceed on. Now we reconfirm the glide path, and this is accomplished by taking progressively longer strokes. When we have a smooth and reproducible glide path, we're ready to proceed to finisher number 1, which has the yellow identification ring on its handle. This instrument is allowed to move easily into the canal and floated to length. Generally, it will achieve length on the first pass. When we've achieved length, the instrument is immediately withdrawn. Now we can irrigate, recapitulate, and re-irrigate. Following the use of finisher 1, which was a 20 at D0 and has a 7% taper, it's time to gauge. Gauging is accomplished by using an ISO 02 tapered 20 hand file. If the 20 hand file is snug at length, we're ready to pack. For first-time Pro Taper users, it's important to appreciate the kind of shape that was just cut, and we can do this by using a series of ISO 02 tapered hand files. Tuning is the clinical exercise where each sequentially larger instrument is placed into the canal. When the handle is snug, the rubber stop is pushed down on the reference point. Recall the 35 through 60 hand files are nickel titanium. These highly flexible instruments will be easily inserted into the canal. When the handle is just snug, the assistant pushes down the rubber stop, and we can begin to see more gap between the top of the stop and the plastic handle. This again reassures us that each larger instrument is moving further and further away from the terminus. To confirm deep shape, we proceed on through the series of hand files. Deep shape is confirmed when each larger sequential instrument is observed to progressively and uniformly back out of the canal. Deep shape creates a more effective reservoir of irrigant and provides the resistance form to hold gutta percha during three-dimensional obturation. The 60 is the last instrument used. The 60 will usually be within about 3, 4, or 5 millimeters of length. A quick way to check your shape is to have the assistants show you the rubber stops and look at the relationship from one stop to the other. Following the use of the 10 and 15 hand files in the coronal 2/3 of the MB2, and after shaper number 1 has expanded the glide path in this region of the canal, we need to make a decision between shaper 2 or shaper X. When the handles of the 10 and the 15 hand files are off axis, then select shaper X because it can be used like a brush to move the coronal aspect of the canal away from focal danger. Shaper X is passively fed into the canal until it encounters light resistance, then withdrawn 1 to 2 millimeters so it is loose within the canal and used to cut dentin on the outstroke. Shaper X is used like a brush to expand the shape and to improve straight line radicular access. When the desired shape has been achieved in the more coronal portion of the expanding preparation, then shaper X may be passively fed a little deeper into the canal until it again encounters light resistance. To clear the debris off the blades, the assistant steadies the hand and plunges the sponge to clear the blades. Shaper X generates an enormous amount of debris, so it's important to irrigate, recapitulate, and re-irrigate. As we've used Shaper 1 and Shaper X, then the optimal shape has been cut in the upper 2/3 of the root canal space. Now we can scout the rest of the canal. Again, a small 10 hand file is carried into the canal, worked up and down in both systems because the systems may in fact be common in their apical 1/3. The 15 file follows, and again it's moved up and down in short amplitude strokes to move debris into solution so it can be effectively liberated from the root canal space. With a smooth reproducible glide path, we can now use Shaper 1 to length. Shaper 1 is carried into the canal and will work primarily at the junction of the middle and the apical 1/3. Shaper 2 now can be carried to working length, and it's again allowed to move into the canal, and the shape can usually be cut in one single pass. Following the use of Shaper 1 and Shaper 2 to length, it's time to irrigate and recapitulate and re-irrigate. The 10-hand file stirs the solution and moves debris into suspension where it can be subsequently liberated from the root canal space. The 15 file follows the 10 and assures us that rotary can follow. It's important to confirm working length at this time because, again, remember that a shorter, more direct path to the terminus exists. Finisher number 1 is the instrument of choice and follows the use of Shaper 2. Finisher 1 is carried into the canal, it's allowed to move just short of length, and then it's immediately withdrawn. This instrument will load up quite a bit of debris and auger that debris out on its cutting blades. Following the use of the Finisher 1, we gauge the size of the framing with a 20-hand file. We tap on its handle to make sure that we can't displace the file periapically. If the file is snug at length, we're ready to finish. A 17% solution of EDTA is flooded into the tooth, and we use a rotary brush to activate this solution. The bristles collapse into the irregularities of the canal and more effectively remove the smear layer so we can get a tighter pack during three-dimensional obturation. Now that we have completed the canal preparation, let's quickly review the ProTaper sequence. In the clinical op, the sequence of instruments used in both the MB1 and MB2 was exactly the same, except when we shaped the coronal 2/3. In the MB1, when the handles of the 10 and 15 files were on axes, we used Shaper 1, then Shaper 2. In the MB2, when the handles of the 10 and 15 files were off axes, we used Shaper 1, then Shaper X. Appreciate that Shaper X may be used in the on-axis sequence to provide more shape as desired. Three-dimensional obturation represents the final step that concludes successful endodontic treatment. In the early 1960s, Dr. Herbert Schilder ingeniously created the warm gutta percha with vertical condensation technique. Over 40 years later, significant numbers of well-trained dentists are continuously selecting this obturation technique because it is simple, efficient, effective, and routinely fills root canals in 3 dimensions. The Schilder pluggers are selected for the warm gutta percha with vertical condensation technique. There are 9 instruments in the set, and the series ranges from the smallest, plugger size 8, to the largest plugger size 12. Additionally, the pluggers have reference lines at 5 mm intervals, enabling the clinician to know the depth of the plugger in the root canal system at all times. Generally, 3 pluggers are pre-fit prior to packing so that the clinician knows with confidence that when a plugger meets resistance, it is on thermosoftened gutta percha and not unyielding dentinal walls. Generally, clinicians fit a fully tapered, non-standardized fine, medium, or medium master cone. Just on the market are color-coded gutta percha points that correspond to the D0 diameters of files. Since we have utilized gauging and tuning procedures, the master cone is carefully trimmed so that its apical diameter perfectly corresponds to the last file that was snug at length. The master cone is measured and notched coronally to correspond to the length of the canal. The pre-curved master cone is placed in a wet canal. When placing master cones into root canal systems, they should be gently moved to length. Curved pulp canal sealer, extended working time, is the sealer of choice when utilizing the warm gutta percha with vertical condensation technique. Curved pulp canal sealer has several advantages. It has unmatched flow and lubrication properties. Its viscosity can be mixed according to the case. It's virtually inert in the periapical tissues. It's essentially non-resorbable. It sets desirably in the presence of heat. Zinc oxide and eugenol combine to form zinc eugenates, a prostaglandin inhibitor. Importantly, curved pulp canal sealer sets within 30 minutes to 2 hours based on humidity. The manufacturer recommends mixing 1 shovel of zinc oxide powder to 1 drop of eugenol liquid. In fact, in a molar, 3 shovels of powder are generally enough material to pack the case. The liquid is dropped into the powder, 3 drops of liquid to equal the 3 shovels of powder. A drop can be placed on the side if we want to decrease the viscosity. On the other hand, we can use 2 drops of liquid with 3 shovels of powder in shorter routes with more open canals. The assistant uses vigorous action and a wide surface area to combine the powder and the liquid. When properly mixed, you can pick the sealer up about 1 inch without it cascading back to the pad. Following drying the canal, the pre-fitted master cone is buttered liberally, and the cone is slowly and carefully teased to place to prevent cement from being displaced periapically. Kerr's 5004 Touch and Heat is a heat transfer unit and is the device of choice for the warm gutta percha with vertical condensation technique. Great dental assisting is important during all steps of endodontics and particularly during the pack. The exchange of instruments benefits the economy of time. The gutta percha gun can be utilized to inject a uniformly thermal-softened segment of gutta percha into the root canal space. We'll talk about this shortly. Let's look at the sequence for packing warm gutta percha into a root canal system utilizing the vertical condensation technique. Generally, 3 pluggers are used for any one root canal preparation, selecting pluggers whose diameters are just slightly less than the canal preparation at any given level. A largest diameter plugger must work passively, unimpeded by dentinal walls over a range of a few millimeters in the coronal 1/3. A smaller diameter plugger is chosen that can work passively but effectively in the middle 1/3. And a smallest plugger is selected that can work easily to within 4 to 5 millimeters from the canal terminus. The pluggers selected must be pre-fit prior to packing so that the clinician knows with confidence that when a plugger meets resistance, it is on thermal-softened gutta percha and not on unyielding dentinal walls. A non-standardized cone of gutta percha is selected that closely resembles the dimensions of the cleaned and shaped canal. Generally, a fine medium or a medium non-standardized master cone is selected and fitted so that the rate of taper of the master cone is less than the rate of taper of the preparation. Master cones are fit to the radiographic terminus and confirmed with the radiograph. The master cone is then trimmed back based on paper point drawing. After drying the canal and placing sealer, the master cone is inserted. The heat carrier is activated and the non-useful portion of the cone is seared off and removed either at the CEJ in single-rooted teeth or at the orifice level in multi-rooted teeth. The objective of this obturation technique is to progressively carry a wave of warm gutta percha along the length of the master cone, starting coronally and ending in apical corkage. The conductivity of heat generated through the master cone is about 4 to 5 millimeters. Compacting thermal-softened gutta percha apically moves this mass into the narrowing cross-sectional diameters of the preparation, creating the piston effect and enormous sealer hydraulics. This completes the first heating and compaction cycle. The probe of the touch and heat unit is introduced into the orifice, activated, and allowed to plunge 3 to 4 millimeters into the coronal mass of gutta percha. The heat activating element is then released, and the clinician pauses just momentarily, allowing the instrument tip to begin cooling, then removes the instrument along with an adhered bite of gutta percha. 2 important events have occurred. The first result of this action is the progressive apical transfer of heat along the master cone another 4 to 5 millimeters. The second result of removing a bite of gutta percha is that a smaller pre-fit plugger can be placed progressively deeper into the root canal preparation where it can vertically pack warm gutta percha. Again, gutta percha will 3-dimensionally fill the preparation laterally and in a depth over a range of 4 to 5 millimeters, producing a second wave of condensation, the piston effect, and resultant sealer hydraulics. Through heating, gutta-percha removal, and vertical condensation of warm gutta-percha, the cycle continues usually about 3 to 4 times, depending on the root length, until the smallest pre-fit plugger approaches the apical 1/3 and can be placed within 4 to 5 millimeters of the canal terminus. Following the final heating and gutta-percha removal cycle, the transfer of heat is progressive into the apical 1/3 of the gutta-percha master cone. The smallest pre-fit plugger can predictably deliver a thermosoftened wave of gutta-percha into the narrowing cross-sectional diameters of the canal, resulting in apical corkage. Sustained vertical pressure with the plugger during the gutta-percha cooling cycle will effectively offset any potential for shrinkage and allow for controlled, predictable apical obturation. Looking at the plastic model, we can see how effectively the pre-fit plugger moves thermosoftened gutta-percha into all aspects of the root canal system. A radiograph at the conclusion of the downpack reveals the enormous hydraulics that's generated with vertical condensation and confirms the pack. Once the downpack is completed, the reverse filling of the canal is recommended. The backpack technique, most efficient, involves using the gutta-percha gun in conjunction with the previously pre-fit Schilder pluggers. The needle is hot, and simply placing this needle against the previously corked apical 1/3 will rethermosoften this aspect of the gutta-percha and allow for cohesion between the aliquot of gutta-percha to be injected and the previously established core. The cycle concludes with a sustained press with the plugger for 5 seconds. This molds the gutta-percha into the shape of the canal and, importantly, offsets shrinkage during cooling. Through a series of gutta-percha injections and vertical condensations, the canal is filled in a reverse manner. The clinician can abort the backpack at any level desired based on prosthetic considerations. Let's look again at the preoperative film of the maxillary first molar where we previously cleaned and shaped the MB1 and MB2 systems. A fully tapered medium master cone is trimmed apically so it exhibits short, crisp tugback. Leaving the medium master cone in the MB1, we select a fine medium for the MB2 and we trim it and size it as previously described. Notice that this cone will not go to length. This suggests the canals merge and are common in their apical 1/3. To demonstrate this, we lift the MB1 cone out, and now this allows the MB2 master cone to be fully seated. This definitively demonstrates that the canals converge in their apical 1/3. The MB2 master cone is additionally trimmed to remove that portion of the gutta-percha that normally would have gone to length. After removing intracanal irrigant using the aspirating syringe, select a prepackaged fully tapered paper point. Paper points are carefully measured at the exact working length. Paper points are gently placed into the canal. The paper points are swirled. This more effectively wicks moisture from the root canal space. We can inspect the terminal extent of the paper point to judge the drying process. Ultimately, we want our paper points to be dry right to the physiologic terminus. We can inspect this point very precisely by looking carefully at the terminal extent of the paper point. That part of the paper point that is just a little bit soft represents that part of the paper point that's minutely beyond the foramen. The next procedural step is to pre-fit our pluggers. We select the largest plugger possible that fits passively in the coronal 1/3 of the root. Next, we select a smaller plugger whose cross-sectional diameter allows it to move deeper into the middle 1/3. We want these pluggers to work passively over a range of a few millimeters. Ultimately, we need to select a smaller plugger that will fit passively within 5 millimeters of the radiographic terminus. The clinician needs to know with confidence that when resistance is encountered, the plugger is meeting thermosoftened gutta-percha and it's not binding on unyielding dentinal walls. The trimmed and radiographically confirmed master cone is buttered in sealer in its radicular extent. The master cone is gently teased into the canal. This allows sealer to be more effectively distributed over the length of the canal. The cone is removed and inspected to make sure it's either uniformly still buttered or there may be a denuded area. In the event there is an area that is devoid of sealer, then rebutter it and gently tease it back to place. This allows air to move more effectively out of the canal. The MB2 is also buttered and seated against the apical extent of the MB1. The touch and heat is activated and utilized to sear off the non-useful part of the master cones. Thermosoftened gutta percha has compaction potential. The pre-fit plugger is used to begin to shepherd and carry a wave of thermosoftened gutta percha into the cross-sectional diameters in the coronal 1/3 of the root. The touch and heat is activated and plunges into the mass. This removes another bite of gutta percha. Utilizing a smaller pre-fit plugger, step it circumferentially around the canal to capture the maximum cushion of rubber. A sustained press for 5 seconds fills the canal laterally and in depth over another 3 to 4 millimeters. The touch and heat now plunges into the MB2, where it effectively pulls out gutta percha. This allows our smaller plugger to work passively, unrestricted by dentin, and again we're carrying a wave of warm gutta percha progressively deeper into the root canal space. The process continues. The touch and heat is activated and is allowed to plunge another 3 to 4 millimeters into the gutta percha mass. A bite is effectively removed, and this allows for another wave of condensation. Step the plugger around the canal. A sustained press moves gutta percha into all aspects of the root canal space. Notice as we pack, we can drive gutta percha through the anastomosing back into the MB1. At the conclusion of the down pack, the gutta percha is leveled off in the MB1 and MB2 systems. We're now ready to backpack. The 23 gauge needle is placed against the previously established gutta percha core. A small aliquot of thermosoftened gutta percha is injected. The smallest plugger steps circumferentially around the canal walls to generate a reverse wave of condensation. We inject more gutta percha progressively into each system, and by compacting this thermosoftened gutta percha into the root canal space, we progress with the reverse filling technique. During the backpacking technique, gutta percha is condensed until the clinician feels it becomes firm. Progressive injection of thermosoftened gutta percha continues into the coronal 1/3 of the root. The largest size pre-fit plugger molds this gutta percha into this space and levels it off at the pulpal floor. This completes the backpacking technique. Here's the post-operative film. Let's review the results. We have straight line access. We have fulfilled the 4 mechanical objectives for cleaning and shaping root canal systems. Notice the 3-dimensional pack. At the completion of endodontic treatment, we should focus on the rest of the seal. In this case, at the conclusion of obturation, a chemical such as chloroform is used on a cotton pellet to remove residual sealer from the pulp chamber. When this has been accomplished, rinse the pulp chamber with 70% isopropyl alcohol to remove any remaining residues. Removing all sealer from the pulp chamber discourages crown darkening and promotes successful bonding procedures. The postoperative film demonstrates the pack. Notice the anastomosing between the MB and the ML systems in the mesial root and the restoration. When endodontics is properly performed, it's the cornerstone of restorative and reconstructive dentistry. This maxillary first molar has had interdisciplinary treatment. The palatal root has been resected, and endodontics has been performed on the buccal systems. Notice the MB root. Between the MB1 and the MB2 there's anastomosing, and off this anastomoses there's another system, and the puff is at that apical portal of exit. There's enormous potential for restorative success if you trust your endodontics. Here's another case that exemplifies interdisciplinary treatment. The buccal roots have been resected off the maxillary first molar. You're looking at the palatal root, the lone pier abutment. Notice the apical bifidity, the outer loop, and a mesial lateral canal to the crest of bone. The result is restorative excellence and long-term success. The future of endodontics is bright, and the most significant advances in the years ahead will be the identification and universal dissemination of the best that already exist and the incorporation of the best, most successful presently developed techniques into your everyday clinical practice. The greatest change in clinical endodontics in the years ahead will be the general acceptance that complete endodontic success is both possible and attainable. Success will be recognized as depending solely on an accurate diagnosis and the thoroughness with which we clean, shape, and pack a root canal system. When this challenging concept is fully appreciated and integrated into all disciplines of dentistry, we will be liberated and endodontics will be fun. Thank you for your time. I appreciate your willingness to expand your abilities, and I wish you great success.